Bismillahirrahmanirrahim. Hi everyone. Congratulations for everyone who have secured a position in intern medicine residency program. We're really excited and happy for you guys. And because of that, I thought maybe I want to share some of my thoughts and give you some topics to read about or be mindful about before you start your residency training. As you know, inpatient rotation, medical ward is really big part of the training program, and per the ACGM requirement, I believe inpatient rotation should be at least 1/3 of the total number of the rotation that you gonna perform during your residency training. So it's a big deal, and I know sometimes at the beginning it might be difficult, especially for those who are not very familiar with the US healthcare system. But believe me, as you go along with it, as you know it, as you train yourself, and as you acquire the skills, you will like it. You will love it. I think it's really enjoyable. But yes, it might be difficult at the beginning, but step by step you'll get there. So I hope you'll find this short video useful to try to prepare you for the inpatient rotation. So let's start. So I will start by, in the next few minutes, just talking about some of the common topics, some of the pathologies, some of the diseases that you might see, and some of the challenges that you might face, just to kind of maybe read about them a little bit and have a big view of these pathologies so that you will be familiar with them. Of course, it's not going to be comprehensive, but at least covers the most common ones that you're going to face, and that your residency program should expect you to be able to handle independently by the time of graduation. So, of course, identifying the sick patient with shock, and abnormal vital signs, they have to come first, right? This is really kind of the key core of the management in inpatient setting. So read about shock, different types of shock. You're going to be called by nurses to evaluate a patient who had a blood pressure is very low or a patient whose blood pressure is very high. So be familiar with that, see how to approach these cases, what are different types of shock, and what to do if the blood pressure is very high, and what are the in-organ damage that you want to look for. So blood pressure and then heart rate. So also you're going to be called to evaluate a patient who has a very high heart rate, tachycardia, or the other way around, bradycardia. And the same thing for patient who has increased work of breathing or increased respiratory rate, and patient who had developed new fever. So vital signs, these are key. You should know them. I know you already have a big idea about it, but try to have a systematic approach to these very common and serious problems. Severe acute pain, how to manage pain in the inpatient setting, what medications to use, side effect of these medications, route of these medications, the WHO ladder, how to go from that ladder from the bottom to the top, what medications should use first, what medications should you use next, what are the contraindications, and how to evaluate a patient with acute pain. So this is very important. Falls and fractures, especially in elderly, also very common theme. What are the factors contributing to falls? What are the things that you need to keep in mind when the diagnosis is mechanical fall, quote unquote? Is it really mechanical fall? Is it something else like syncope? Is it seizure? Something that's more serious maybe. And also evaluating patient for injuries. And sometimes you might be called in the floor to evaluate a patient who actually fell while hospitalized. That's important as well. Perioperative medical management, that's really key. You will going to be managing medical issues with patients who are co-managed by your colleagues in surgery or other department that they need your medical expertise to help them manage this patient. So patient who are going into surgery, you need to know if there's anything medically need to be done before the patient can go for surgery. Some people call it like medical clearance, but basically the main question is it safe for this patient to go to surgery without any particular medical intervention? Leaving against medical advice, some people call it AMA, also very common theme. You need to have an idea what to do when the nurse calls you, hey, your patient is wanting to leave the hospital, and you think there's some other medical treatment that needs to happen before the patient can safely go to their home or to their destination. How you can handle that. And on the other hand, sometimes patient might deem to be appropriate for discharge, but the patient disagrees with you and they feel like they still need to be admitted, they still need some testing, they still need some care before they go to their destination or home. So how to handle that situation. And then determining decision-making capacity also is very important part of wards. Very common, you might see patient admitted with some cognitive, neurological issues or psychiatric issues. And sometimes it's very clear that they cannot make decisions for themselves, but sometimes it can be really challenging. For example, patients with mild dementia and still have capacity to make decisions for themselves, even if the family might not think so. Also, some patients with psychiatric disorders, patients with mild schizophrenia, if they're not having acute psychosis, some of these cases, they still can have decision-making capacity, or DMC, some people call it. So you need to evaluate components of decision-making capacity and how you can apply that. All right, when it comes to the cardiovascular system, you'll definitely see a patient with acute chest pain. You're going to be admitting patient with acute coronary syndrome rule out to see if the patient is having unstable angina or an ST elevation MI or even ST elevation MI. Patient with acute chest pain always need to be evaluated for acute aortic syndromes. They're definitely much less common than ACS or acute coronary syndrome, but they are really very important to keep in mind and maybe rule out at the beginning. Pulmonary embolism can be very tricky diagnosis. Keep that in mind. Learn how PE can really present in a very atypical ways, really very atypical ways. I have seen it unexpectedly in many patients, and you really need to have a low threshold to diagnose these patients. So be familiar with atypical presentation of pulmonary embolism and how to manage them when you discover them. Acute pericarditis, pericardial disease in general, pericardial effusion or tamponade, also relatively common. You're probably going to see it. So these are probably the cardiovascular causes of chest pain, but remember GI and musculoskeletal are probably much more common, but these are the most serious ones that you need to keep in mind. So be familiar with them. CSF exacerbation for sure, very common theme. Be familiar with likelihood ratios for diagnosing heart failure at the bedside, how useful the history is, the physical examination, the basic lab testing and imaging, and what the goal-directed medical therapy for these patients and how to handle complications of CSF exacerbation and discover the underlying causes of the exacerbations, which are very many, but they're really important. Hypertensive crisis, we talked briefly about that in the previous slide, how to differentiate hypertensive urgency versus emergency, what medications to use and what medications not to use when you're called to evaluate a patient with very high blood pressure. Arrhythmias, atrial fibrillation is probably the most common one that you're going to see, and atrial flutter as well, especially if they have rapid ventricular response or RVR. VTAC, also very common. Patient in tele, they might have sporadic episode of VTAC, so you need to know how to evaluate that and how to treat it if it becomes persistent and became an issue. Bradycardia and heart block, also very common. What to do, what are the different types of heart block, how to recognize them in the ECG, and how to manage them. Syncope evaluation also is very common to have a patient coming in with loss of consciousness, and sometimes it might be tricky to differentiate between dizziness, loss of consciousness, syncope, presyncope, seizures, falls, even like drop episodes out of the blue. So under cardiovascular, of course, cardiovascular syncope is something that you always need to keep in mind and rule out, but it's not the most common cause of syncope. And also you need to be aware of how to really to over test these patients, because it happens commonly in wards. And then limb ischemia also, you're going to see a lot of diabetic patients coming in with various degrees of limb ischemia. Pulmonology, evaluating patients with acute shortness of breath, also a very common theme. So you have to be able to differentiate causes of acute versus subacute versus chronic shortness of breath, and the important causes versus the less important causes. And by the way, I see the images you see at the background is kind of weird. I know I asked AI to give me some images to have as a background. For some reason, they just decided to make the lungs really looking funny. So I don't know why, but it is what it is. That's how AI works. Hopefully going to get better in the future. Anyways, hypoxia and hypercapnic respiratory failure, also very common. Be familiar with how to identify these patients, how to treat them emergently, and then how to think about the underlying causes and stabilize them as well. Evaluating patient with cough and hemoptysis, patient with pneumonia versus pneumonia mimics. A lot of things can look like pneumonia, so be aware of that. And patient with acute asthma, COPD exacerbation, also very common theme. How to evaluate this patient and how to provide acute care and how to prepare them for outpatient follow-up appropriately and follow the guidelines. Large pleural effusion, recurrent pleural effusion, also very common. What are the common causes, less common causes? What are the blood tests, serum tests, and pleural fluid tests that you need to order for these patients? Evaluating patient with interstitial lung disease, and especially when they come in with acute exacerbations, how to treat them, and when to get pulmonary service pulmonologist involved to care for them with you. Evaluating patient with lung mass, also very common. What are the risk factors associated with that? Is it serious? Is it not serious? And how to do appropriate follow-up for these patients when they get discharged. And of course, ICU stuff, especially ventilator management. Try to have some ideas if you haven't been exposed to that before, because it's really can be challenging sometimes when you're starting your ICU rotation. Infectious disease is very important, very common. Pneumonia or not, very important. Depending on when you practice, I'm here in Fresno, Central Valley in California. Coccidiomycosis is very common. Actually, I have seen a patient today with it. COVID and COVID complications, it's still there, but thanks God, we're over the pandemic, which was very distressing for everybody. But pneumonia is very important to know things that look like pneumonia and bacterial pneumonia versus viral pneumonia versus fungal pneumonia, and how to evaluate these patients. Skin and soft tissue infections, diabetic or non-diabetic. Patient with diabetic foot infection commonly get admitted in the hospital. Cellulitis, sepsis, necrotizing fasciitis, very important diagnosis to keep in mind. And osteomyelitis sometimes can be missed also if you're not careful. So very common pathology. UTI, pyelonephritis, cystitis, also very common. Can be challenging sometimes, can be straightforward. And what antibiotic to use, what are the complicated cases versus less complicated cases, and how to, when to get infectious disease consult on board. Bacteremia, infective endocarditis, also very common, how to handle gram-negative bacteremia versus gram-positive bacteremia, and importantly, how to identify the underlying source and how to manage those, and the duration for antibiotic in these patients, and what are the faraway complications that you need to keep in mind. Is the patient high risk or low risk patient? These are really important. Gastroenteritis, food poisoning, Clostridioides difficile or C. diff, infection, also relatively common. When to start antibiotic, when not to start antibiotics. What are the sensitivity and specificity of these tests we use to diagnose, when to order stool testing for ova and parasite, when not to order stool for ova and parasite. Arthritis, a little bit less common, but it's still important to recognize how to differentiate infectious arthritis from other inflammatory arthritis. Meningitis, encephalitis, patient with fever and altered mental status who are likely needing a cerebrospinal fluid evaluation. What are the possible underlying causes? Is it infectious encephalitis or non-infectious or autoimmune encephalitis? It's not uncommon to see non-infectious causes of encephalitis in the inpatient setting, and also what orders you need to order for in the CSF to make sure that you are catching really the common causes of encephalitis or encephalopathy in these patients. Fever of undetermined origin of unknown source, also relatively, it's not very common, but you'll see it. How to have a diagnostic approach for these patients in infectious versus non-infectious causes. Of course, most of the time you need the help of infectious disease and possibly rheumatology as well, if you have that. HIV and other STIs or sexually transmitted diseases like syphilis and others, be familiar with those, and how to, most of the time, honestly, you will need infectious disease consultation for these patients, because sometimes it can be really complicated and they have a lot of common and uncommon diseases associated with this syndrome. Endocrinology, of course, diabetes, DKA, inpatient management of hyperglycemia and hypoglycemia. You should know it in and out. This is very common and very important to handle, and can be really serious. So familiarize yourself with the types of insulin, types of other non-insulin medications. There's a lot of new medications that now are coming in. Try to know which one can be used in the hospital and which one cannot be used in the hospital. But of course, insulin is a big one. That's one that you most commonly you will use in the inpatient setting. So definitely be familiar with hypo and hyperglycemia protocols. Hyperthyroidism and hypothyroidism, probably the next common endocrine issues that you'll see. How to interpret TSH in the floor. I have a video about that if you want to look at it in my YouTube channel. And how to manage these patients. Most of the time, if they're sick, you will need an endocrine service help. Hopefully you have that in the inpatient setting. Hypercalcemia, also you will see many cases of hypercalcemia. Some of them are stable, some of them are not. How to do a diagnostic approach for these patients and how to manage them in the acute setting, very important. Adrenal insufficiency, of course, very important, but it's not common, honestly. You might not see the classic adrenal insufficiency patient commonly in the ward, but it's always a diagnosis that you need to keep in mind. So read about how to diagnose adrenal insufficiency, what are the conditions associated with it, and what are the atypical presentation of adrenal insufficiency. I think that will be key. And then you will encounter a patient who had imaging in the abdomen, and then they discovered they have adrenal mass. So what test to order for that, and how to approach patient with adrenal mass. That's also very important. Nephrology and urology, acute kidney injury or AKI, probably the most common application that you might see related to the kidneys in the ward. How to differentiate between different types of pre-renal, renal, and post-renal AKI, and how to manage those. Electrolyte disturbances, hyponatremia, probably the most common one, but abnormalities in potassium, phos, and mag, this is also very important to know. Hypernatremia also as well. I also have a video about hyponatremia and hypernatremia, so you can take a look at that, and hopefully you will find it helpful. It can be very challenging sometimes to manage these patients, so familiarize yourself with them. They're very common, and know how to replace them appropriately, and when do you need to replace them aggressively in certain cases. Patient with end-stage renal disease, patient on hemodialysis, or even sometimes peritoneal dialysis, and coming with their complications, especially resistant hypertension, anasarca, fluid overload, electrolyte abnormalities like hyperkalemia, severe acidosis, or uremia. These are very common complications, so familiarize yourself how to handle those. Renal stones, also common, depending on the size, depending on the location, depending on the kidney function. You need to know how to handle them, and how you, or actually when you need to call urology service on time, and when they're really needed emergently versus less urgently. Hematuria, very common presentation. Familiarize yourself with the different causes of hematuria and how to approach this problem. Patient with nephrotic syndrome, not very common in adults, maybe more common in kids, I would say, but it's still diabetic. Nephrotic syndrome is relatively common, so you need to be familiar with that and how to manage those. Transplant kidney patient, you'll see many patients with transplants, depending on where you're going to practice, but you really need to familiarize yourself with the medication that they use and their complications, and the infection that can be associated with the transplant kidney patient, and complication that can happen on the long run and the short run for transplantation. And of course, most of the time you'll need the help of your nephrology colleagues, and some hospitals, they have like dedicated services for these patients, which can be very helpful. GI and hepatology, you need to evaluate patient with acute abdominal pain, and I'm currently doing a series of that. Patient with acute pancreatitis, most likely, definitely will see some of those. Diverticulitis, cholecystitis, peritonitis, colitis, different type of colitis. I'm hoping that you'll find the video I make about abdominal pain useful, so you can take a look at that. Big topic. Evaluation of patients with acute vomiting and acute diarrhea, and how to handle these patients, how to evaluate patients with hypovolemia and dehydration, and when to start antibiotic, when not to start antibiotic, and what could be the different causes, and what are the important causes of acute vomiting and diarrhea. Decompensated cirrhosis and complications of cirrhosis, also very common, including GI bleeding. Upper airway GI bleeding, you'll see it all the time. Also be very careful about how to manage these patients, because sometimes they can really deteriorate quickly if you're not careful. Bowel obstruction, also very common. So the time you will co-manage this patient with your surgical colleagues, so you need to know how to call them urgently and how to manage those conservatively initially, and then have them on board a little bit later. Abnormal liver function test, also very common. A lot of patients will have abnormal liver enzymes or abnormal liver function tests in general. They might have jaundice, clinical jaundice, or biomedical jaundice, hepatitis, biliary obstruction, how to differentiate between hepatocellular injury and obstructive pattern of abnormal liver function tests. Dysphagia, also a very common symptom to see and to know about. Failure to thrive, malnutrition, also can be very challenging sometimes, and usually associated with chronic problems, including cancer, and how to approach those with the help, of course, of nutrition support in your hospital. Abdominal mass, also very common theme, especially if it's seen incidentally on imaging, and how to approach different abdominal masses depending on the location of the mass. Hematology and oncology, evaluation of severe anemia. This is also very common. Need to be fever, very serious diagnosis, what antibiotic to start, what are the potential sources, who are the high-risk patients, who are the low-risk patients, and of course, most of the time we're going to manage this patient with our hematology, oncology colleagues. Acute leukemia, lymphoma treatment, patient coming with non-specific symptoms, and then they have very abnormal blood test suspicious for leukemia or lymphoma. They might come in with chemotherapy side effect or chemotherapy complications, how to support them during that critical part. Of course, most of the time you'll have your hematology oncology colleagues as well, but acute medical management, really important part of the general medicine treatment. Abnormal CBC, severe or new pancytopenia, how to approach this patient. Of course, again, most of the time you'll need the help of your hematology oncology colleagues, but you need to have a general idea what are the potential causes and how to approach complications that can arise from severely deranged CBC. Pulmonary embolism, DVT, and other thrombotic disorders relatively common, but other complications that can happen. We talked about how PE symptoms can be very tricky, so keep that in mind. Have low threshold really to test for pulmonary embolism in patients. In neurology, encephalopathy, altered mental status, very common theme. Very broad differential diagnosis. You really have to have a structured approach for this patient, and hopefully I will make a video about that because I think it's a really important topic that sometimes can be mismanaged. Stroke, TIA, cerebrovascular accident, how to evaluate this patient and how to initiate acute medical treatment. Most of the time you need the support of your neurology colleagues. Many hospitals now, they have protocols for, a stroke rule out to see which patient need acute management and thrombolytic therapy. New onset muscle weakness or sensory symptoms are very common, but very important. Sometimes can be very tricky and very vague, and you might not reach the diagnosis right away. With the help of your neurology colleagues as well. Acute dizziness, vertigo, very common. Sometimes can be straightforward, but sometimes can be very challenging as well. Many times you don't want to miss important diagnosis like a posterior circulation stroke, for example, in this patient, especially if they have risk factors. Seizure disorders, different types of seizures, and side effects of seizure medications and how to stabilize the patient with acute seizure. Also important. Multiple sclerosis flare-up, you might see it every now and then depending on where you practice, how to diagnose those, and what are the diseases that can look like MS flare-up, but they're not MS flare-up. New severe headache, also common in the inpatient setting. Is it a serious headache? Less serious headache, but any headache can give the patient headache and you as well. So you need to know how to treat those and how to sort out the serious ones from the less serious ones. Dermatology and rheumatology, immunology and allergy. New skin rash, relatively common. What are the serious rashes? What are the common ones, less common ones? If you have inpatient dermatology, that would be helpful, but not all the hospitals have those. So you need to recognize serious causes of skin rash and what are the alarming features of skin rash in the hospital. Anaphylaxis, severe allergic reactions, also relatively common. You'll see that most of the time they're severe. If they're severely sick, of course, they will end up in the ICU. SLE, rheumatoid arthritis, flare-up or complications, other rheumatological conditions. You must see that every now and then. If you get the help from rheumatology in service, that would be nice, but not all the hospitals have the luxury of patient rheumatology. Therapies for common rheumatological disease. Also, you need to be familiar with the side effects. Many patients might come with complications of those, so be familiar with these medications. Medicine and psychiatric disorders. Patients with acute psychosis, and what are the differential diagnoses, what are the contributing factors, how to manage those, what are the side effects of antipsychotic medications, do they need inpatient psych evaluation. And again, most of the time you'll have the help of your psychiatrist colleagues so they can give you some advice. Alcohol intoxication withdrawal, you need to learn how to manage those, also very relatively common and can be very serious if mistreated. Substance use intoxication withdrawal like opioids, methamphetamine, marijuana, cocaine, depending on when you practice. Some of these are really common. Here in Fresno, methamphetamine is really a relatively common problem, so you need to familiarize yourself where you're practicing, familiarize yourself with these disorders as well. Somatoform disorders can be challenging sometimes, but it's there, and you need to be familiar with how to evaluate this patient when you're suspecting it and how to appropriately handle and in these cases. So a lot of these topics and diseases I mentioned, you probably know from medical school. You've probably seen many cases during training at medical school and after in your practice after medical school. But I really just wanted to kind of give you a brief overview of those so that you can familiarize yourself more with them, because they're really very common and you're going to see many of those during your training. The inpatient rotation, basically the goal of that rotation is to train you to be a competent acute medicine physician or hospital medicine physician or hospitalist. So basically hospitalist is a relatively new term in medicine. It's probably the most expanding specialty in general internal medicine, and hospitalists, they consider themselves primary care providers for hospitalized patients, and that's why you really need to kind of have a very wide knowledge base and have to handle a lot of these issues. So as you probably know, hospital medicine, again, is a growing field of general internal medicine. Many of these hospitalists. They're part of the Society of Hospital Medicine or American College of Physicians. Some of them work exclusively as hospitalists. Some of them actually work both as hospitalists and primary care providers in the outpatient setting. You probably during residency, you might need to be a member of the ACB and probably also a member of SHM, especially if you are thinking about going into hospital medicine. Skills of hospitalists, again, wide knowledge base and diagnostic skills as we talked about. This is very important. Communication skills is really very important. Most of the mistakes that happen in the inpatient setting is because of lack of communication. Communication skills between you and the nurses, you and the ancillary staff, you and the patient, you and the family of the patient, and everyone is taking care of your patient. This is really key to kind of optimize the outcome for your patients. Time management and efficiency, this is very important. You will, because you need to present during rounds, you really need to know how to figure out how to manage your time. When you get in the hospital in the morning, get the sign out from the night team and go and see your patients before rounding. That's very important to try to get your own tools and your own style and the thing that you can do more efficiently early on, and then practice those and master those as you go through your training. Documentation skills, that's very, very important. You have to pay attention to how to rightly document your history, your exam, your assessment and plan, and the event that happened with your patients. For hospitalists, POCUS is a point of care ultrasound is really a growing skill now, and it's gaining a lot of popularity. I personally love my ultrasound. I use it almost every single day with my patients. I found it really very useful, not just for procedures, but even outside for procedures. Diagnostic ultrasound is really very helpful. So try to have an idea about what POCUS is if you're not familiar with it. Get familiarize yourself with maybe at least a basic of point of care ultrasound before you start your training. Again, it's not just for inpatient. A lot of subspecialists, outpatient setting, they're really also finding POCUS very useful. So nowadays you have to familiarize yourself with the electronic medical record because all the hospitals, all the facilities use it. During my residency, it started to be mandatory, but now it is. So know which electronic system your hospital use, and as you go through your training, you really try to make the electronic medical record your friend. Try to know how to navigate the different buttons, how to really take advantage of a lot of properties that many of us maybe they don't even know. And I'm sure that if you really master the AMR in your rotation, you will be really efficient and you will be able to really provide excellent care for your patients. Clinical skills and time management, we talked about that. So know how to really take efficient history and focus history, not to be distracted by things that are not necessarily helpful to make the diagnosis for your patient. We talked about physical exam and POCUS, point of care ultrasound is considered part of physical examination. It's kind of an extended physical exam, give you more information. And then bedside manners and communication skills, that's also very important. How to manage your time with the patient at the bedside, knowing that you have to leave the room in a timely fashion because you need to be ready for rounding and not to waste your time with unnecessarily talks that's not really helpful for you or the patient. Documentations, I have a video also about that, so you can take a look at it in my YouTube channel. Know what the program is evaluating you for. Basically, the residency program evaluating you for the ACGME 6 core competencies, and I have a video about those, and I really encourage you to take a look at those. Be familiar with what these are, because this is basically what your program is evaluating you for, and you need to master these skills before graduating. And if you're lagging behind in any of those 6 core competencies, then you need to seek some help and try to develop your skills and get it better so that you feel comfortable practice on your own when you graduate from your residency training. Keep medical knowledge handy. Really try to familiarize yourself with the resources for medical knowledge and how to get quick information. UpToDate is a very popular one. Access Medicine is one of my favorites. Almost a lot of books, a lot of textbooks, a lot of resources available, and most of the program they have free access to that. It includes my favorite textbook, Harrison, but many others. Some of them have also like free focus book, which is very nice, very brief and concise. Of course, the ACB had their mix-up. You're probably going to have free access to that through your residency program. Very nice, concise book, very updated and evidence-based. Really master that book. If you read it multiple times before graduation, I guarantee you that you'll be really comfortable during your board exam and during your practice as well. Dynamidex also should be free if you have an ACB membership. I love it. It's I personally prefer it over the other resources. I check it all the time. Very organized, and it's very evidence-based, very helpful resource. And I'm sure they're gonna have like I don't think they have AI yet, but I'm sure they will have it soon. And it's also a very nice source for medications. They very organized in terms of side effects, dosages, what to patient education, what to tell your patients, many others. Really very nice resource. And of course, AI. There's a lot of AI resources that you can actually use in daily practice. ChatGPT, Open Evidence. I love this one. I use it all the time. DeepSeek, not very robust when it comes to medicine, but it's still very useful, and I use it quite often. Still, when it comes to references, it's like a ChatGPT initially. Sometimes it even create like a false reference, unfortunately. So I'm hoping it's gonna get better down the road, but still, for many questions, they really gave me really very nice organized answers. Clinical Key, I don't know if most programs offer that for their residents, but they have a really nice AI tool as well for like clinical questions. So ask your program if they have that. I found really very useful as well. Guidelines, always know the guidelines, the important ones. For example, the Infectious Diseases Society of America IDSA guidelines, very big when it comes to infections and antibiotics. American Heart Association, of course, and others. Really familiarize yourself with the guidelines when it comes to common diseases, because basically this is what the broad Society of Medicine agreed upon. And of course, guideline doesn't mean like you have to apply every single guideline to your patient. You have to individualize the management approach, but it really kind of give you like what's the standard of care in that area that you're looking at. Now, know the other ancillary staff that take care of your patients, including physical therapists, occupational therapists. You're going to consult those quite often. Know who are the patients who need physical therapy and occupational therapy. Not all patients need those who are like independent. Even when they get hospitalized, they're walking around without issues. They don't need PT or OT, obviously. Speech and language therapy, also very common consultation that you might need. Respiratory therapists, especially in the ICU, very helpful. Make them your friends. The ICU. Consulting ethics committee, sometimes you might need that if you encounter a difficult case with some ethical dilemma. So, obviously you'll talk to your attending about that, but at least have some idea about what ethics committee is and what they do and when you need them. Social workers, very helpful ancillary staff that you need in the inpatient setting. So basically they're really trying to help patients finding community resources to improve their health in various conditions, including substance use, mental health issues. Any of the social workers, they might be like licensed clinical social workers. This CSW, so this actually can provide basic advice about mental health, and or even like give the patient basic resources to get some help when it comes to mental health. If you have, for example, suspicion for abuse, like domestic violence or like elderly abuse, you might seek their help as well to start some process and looking into that. And if you have some insurance issues, they're very helpful when it comes to that as well. Some of them might give the patient some resources to get their medications if they're really having insurance or having insurance issues. So social work consult, very common, very helpful. Same for case managers. Also, most of those are like registered nurses, very, very helpful when it comes to barriers for discharges, and also when you want to coordinate the care of your patient. So, for example, if the patient needs some home health services, they need to go home with IV antibiotics or physical therapy or occupational therapy at home, or they need home oxygen to be arranged and delivered, or any durable medical equipment they need, like hospital bed or bedside commode, any devices that they need at home. The case manager will ask you to put these orders, and they can work on getting these delivered to your patient. Arrangement of follow-ups for primary care doctor or subspecialist in the community, they can help you with that. Sending queries to rehab or rehab hospitals or facilities when your patient needs to go to rehab facility upon discharge. They will help you with that. And also, if the patient has transportation issues, they can help you with that as well. And transferring patient to another hospital, they also can get involved and make the transfer happen. So case management consultation, also very common. Be familiar with that. And then the discharge process sometimes can be straightforward, sometimes can be challenging. Me myself, during my resident training, I really have no idea that discharge process can be very complicated sometimes. So the simple one, of course, is the patient is ready to go home independently. That would be the best. Home sweet home. But sometimes they really need some help at home, And this is when you get the social worker and case manager involved to provide the patient with home health services according to their medical need. Unfortunately, some patients might not have home, and you might need the help of case manager to see if they can arrange some shelter for them upon discharge, room on board, another place they can go to, and also they can give them some basic services if they don't have access to that. Assisted living facility or board and care if they need a little bit more help going home. This can be another option for some patients. Short-term rehab, basically just another hospital, another facility where the patient can stay for a week or two to get some management, dedicated management before they go home. For example, stroke patients, they might need a little bit of more extensive physical therapy or occupational therapy or speech therapy before they go home. They can really benefit from being in this facility, short-term rehab, for like a week or two before they can go home. Skilled nursing facility, if they need a little bit more subacute rehab or long-term rehab, and the patient need nursing care, this is also, they need to, you need to have some arrangement for these facilities, and of course the case management can help you with that as well. And those who really need dedicated specialized care, they might need to go for long-term acute care. A classic example would be patient on ventilator. If they are stable enough to go on with the ventilator, they will need to go to specific facilities, and it might be a little bit challenging to get in some places, but the case management can help you with that. So this is just an overview of how the ward rotation looks like, the thing that you may be doing from March to when you start your rotation in June or July, that you need to kind of familiarize yourself with. So do basic reading, talk to your friends who are in residency about those, and hopefully you'll find this video useful to get you starting your inpatient rotation. Reach out to me if you have any questions, and good luck to you all. And believe me, it's very enjoyable rotation. Difficult at the beginning, but you'll like it. Take care. Bye-bye.